Welcome to Retina Health for Life from the President's Corner, brought to you by the American Society of Retina Specialists. I'm your host, Dr. Tim Murray, coming to you from Miami. On each episode, we'll bring you inspiring conversations about your sight and the special role the retina plays in making healthy vision possible. We'll hear from expert retina specialists as well as directly from patients about living life to the fullest with retinal disease. Join us and learn how to safeguard your retina health for life. Welcome to ASRS's Retina Health for Life from the President's Corner. On this episode, we're going to speak about diabetic retinopathy, particularly focused on the advanced surgical procedures that are available to retina specialists to treat this debilitating condition. It's my pleasure to welcome to our show my colleague and close friend, retina specialist Dr. Maria Berrocal, who practices at the Berrocal Retina Institute in Puerto Rico. Maria, welcome.
Thank you, Tim. It's a pleasure being here.
So, Maria, this episode is focused on diabetic retinopathy as an overall approach to management, but really looking more concretely on surgical repair. And for me, you really are one of the world's experts on surgical management of diabetic retinopathy. And at this time where we're seeing diabetes increase almost exponentially in our population, it's a little disappointing to me that we're seeing patients present with still very complex active disease. So I'd like to have you have the opportunity to share some of your knowledge and experience, taking us through some of the common signs and symptoms of disease, some of the testing that you perform, and how you approach and manage your surgical patients in and out of the OR.
Yes, thank you, Tim. I am very concerned with the increased incidence of diabetes, and this is a real problem worldwide. It is a huge health issue. Sadly, many diabetics go undiagnosed until very late in their disease. So there's a lot that we can do from a primary care setting. But whenever I get a diabetic patient, and sometimes I get patients with diabetic retinopathy, very advanced, who don't even know they're diabetic. The first thing that I do is I talk to them about diabetes. Many of them really have no concept of what a diabetic diet is. So I start by explaining what diabetes is, how control is so important. I ask them about their hemoglobin A1C. Many of them may not know what it is or have ever had it done. So I really communicate with their primary doctors about this. Sometimes I just send them to a physician. I order labs. And I made a printout of a basic diabetic diet with basic guidelines. It's very simple. It has columns yes and no of things that they can and cannot eat. For example, there's some misconceptions like it's okay to eat raw sugar but not refined sugar, things like that. So I think education is really key with these patients. The next thing that I do is I do imaging on the first visit always. I try to do a fluorescein. Sometimes they're alone or, they may not want a fluorescein, but I do wide angle photography. I think it's very, very important to show patients what they have. I also do an OCT, as many may have macular edema upon presentation.
So Maria, the fluorescein that you do, can you tell our audience what that is and why it's important potentially in diabetes?
Yes, well, diabetes really affects the circulation of the small vessels in the body. So it is very important to see how it is affected. And the retina is a privileged area of the body because it's really the only place where we can actually see the blood vessels directly because the retina is transparent. So a fluorescein really shows in detail. It's an angiogram of the retina. So it shows areas where there's no circulation, areas where all of the circulation has been lost or blocked off. which explains why many diabetics then get amputations of the legs and whatnot. So I think it's a really nice tool for me to know how advanced the disease is, to get an idea. If they have a lot of areas of lost circulation, I know that these patients are going to progress fairly quickly, and it really decides how we're going to manage them. It also shows areas of leakage and areas of edema, and the same, swelling and edema that occurs in the retina occurs in other parts of the body. And we also know that the eyes and the kidneys are the two organs that are first affected by diabetes, because they have small vessels. So we really have to pay attention to the kidneys and send their primary doctor information so that they may be put on either a renal diet or on medications to protect the kidneys.
And then you also mentioned something that I think we're using more and more, which is ultra wide field photographic imaging. Why do you think that's important for this particular patient?
Well, because wide field photography has been really a game changer in the way that we can view the eye. Normally, in normal photography, you need to have a dilated pupil. You need to take many shots of different areas of the eye. But with wide field, just with one picture, and you can do it without dilation. So it's readily available, to do under first visit, and you can do the angiogram there too. And you see all of the field of the eye all the way almost to the periphery. And in diabetes, oftentimes you can have a fairly normal looking center of the eye with severe ischemia and loss of circulation in the periphery. So in particular for diabetics, I think it is extremely, extremely useful.
And then the other thing you've talked about is the OCT, or optical coherence tomography. What does that information relate to our patient with diabetic disease?
Well, an OCT is really like a pathology slide of the retina. And we can use it in different parts of the eye, but it is particularly useful in the fovea, or the macula, in the center of the vision. Because when we have swelling and we have fluid accumulate in that area of the eye, usually visual acuity decreases, and that is the area most important for central vision and for near vision, in particular, and precise vision. So we really want to know that is affected so that different treatments can be started. With diabetes and diabetic damage, the earlier we start treating affectations, the better our outcomes are going to be.
So one of the things we've come right to the patient that has made it to our office. For our patients that haven't seen us yet, seen a retina specialist, what do you recommend that they look at from terms of signs and symptoms that should have them seen by a retina specialist?
Well, if a person knows he is diabetic, changes in their vision, oftentimes when they have uncontrolled diabetes with fluctuations of vision, the lens of the eye swells and their vision fluctuates. They may not be able to see as well. But the main symptoms are seeing floaters that can be a sign of bleeding inside the eye, or seeing some distortions or seeing blurry, which can be signs of edema. So I would say those are the main things. Also, there's certain populations that are more prone to diabetes. Hispanics are more prone. African Americans have a higher incidence. American Indians have a higher incidence genetically. So if you are among those groups, or if you're overweight or obese, you're over 40, everybody should be screened for diabetes.
Yeah, I think the idea of screening is so important for our patients and our potential patients, and also the symptoms that we ask our patients to look for to get them to see us are the same ones we want them to monitor for while they're in our care. So one of the things that I think that I've seen really a shift for is, surprisingly, it seems to me that we're seeing more diabetic patients, which is not unexpected, but we're seeing more advanced disease in the diabetic patients that are presenting to us. Do you see that in Puerto Rico also?
Oh, yes. Puerto Ricans genetically have one of the highest incidence of diabetes in the world. So I would say a very large percentage of my practice is diabetic retinopathy. And I sadly see many patients who come in already with very advanced disease, proliferative diabetic retinopathy, very advanced macular edema. With diabetes, like with many diseases that don't give you, any pain or any symptoms really until the damage is already done, patients may be in denial. They've been told they have diabetes, they should do a strict diet, but they don't until they start having problems. So I do see them in very advanced stages. And then, my approach is different. It's not so much a preventive approach, but more of a treatment paradigm.
Right. So Maria, what's interesting is you and I have practiced long enough to see a transition where the treatment for advanced diabetes was laser therapy to this new advent of intravitreal injections with anti-VEGF. Can you comment on that transition and how that's impacted your patients?
Yes. Well, in the past, we had a fairly good treatment for proliferative disease, which was laser photocoagulation, but we really did not have a good treatment for macular edema. In macular edema patients lost vision, and treatment with laser did not really offer a good alternative. It caused scarring. The scars grew over time, and it did not really improve vision in all the trials. But with anti-VEGFs, we have a means of improving the vision of these patients with macular edema. And macular edema can resolve, and they can preserve their central vision. And also in patients who have advanced non-proliferative diabetic retinopathy, it can help patients, it can prevent patients from progressing to more advanced stages of disease.
So it's interesting. So the initial trials were really focused at using these injections to treat the leakage in the central retina, which was blurring the vision, and was in fact, in the US, the major cause of legal blindness in that population over the age of 40, under the age of 65. And then it's interesting, Maria, that we saw the benefits to the injection for the macular edema, and then we had this observation that the abnormal vasculature outside of the macula improved also. So can you tell our audience what proliferative diabetic retinopathy is and why it's important to recognize that?
Yes. In diabetes, as I was explaining, it damages the small vessels. So the small capillaries inside the eye, they get damaged. They first, the wall becomes leaky and it leaks fluid out. It leaks the serum and the lipids. So we get a swelling of the retina with accumulation of lipid and hemorrhages. But over time, when the vessels get more damaged, they close off completely. So we have areas that have no circulation. And as a desperate means of, the eye seeking food and oxygen, it starts producing abnormal vessels. It's a very similar thing that what cancer cells do. It forms new vessels to grow and to get, circulation. And these abnormal vessels tend to leak more, tend to hemorrhage more. And in young patients in particular, they can grow into the center cavity of the eye or the vitreous, where they can be pulled by different changes in the eye and cause retinal detachments and severe visual loss. And fraction retinal detachments is really one of the most common pathologies in younger diabetics.
So Maria, you mentioned the vitreous. We've always felt that the vitreous, that jelly that fills the posterior cavity of the eye, that's a critical factor in the progression of diabetic proliferative retinopathy to cause retinal detachment. Can you explain to us what that vitreous acts as?
The eye is filled with a transparent gel, which is the vitreous, and it is attached to the back of the eye to the retina. And the abnormal vessels, these neovascular vessels, can use it as a scaffold, and they grow into the back part of the eye. So they're held there, and with movements and changes in that gel, it pulls on these abnormal vessels, and they either bleed or they can, if they're pulled very strongly, they can detach the retina. And we know that in diabetic patients that have proliferative disease and the vitreous gel is attached or partially attached, they will all get bleeding and traction areas. Whereas if it's an older patient where this vitreous gel has already detached, because a normal part of aging is that changes occur to the vitreous gel that cause it to separate from the retina. It is a normal part of aging. And once that occurs, the abnormal vessels don't have a scaffold to grow into. So it is, in a sense, protective for patients with proliferative disease that keeps them from developing traction retinal detachments.
So Maria, when patients develop the hemorrhage in the vitreous or vitreous hemorrhage and it doesn't clear, we then offer them surgical intervention. When they get a detachment, whether it's tractional where the retina scars and pulls, or whether the retina actually tears and there's what we call regmatogenous component to the detachment, again, the options for those patients are all surgical. You've been involved in many of the major surgical advances with the approach to proliferative diabetic-related disease. Can you tell us what you think some of the biggest advances have been in your practice for your patients?
Well, really, vitreous surgery has evolved incredibly, particularly in the last, I would say, 10, 15 years. What has happened is that, before, when we did vitreous surgery, we had big incisions that caused some bleeding postoperatively. We had some of these incisions would not close really well. It was very hard to control the pressure during surgeries. Patients bled a lot. And really repairing some of these very complicated cases was very difficult and cumbersome. But recently, what has happened is that vitreous surgery has really evolved. We have better machines that control the pressure really exquisitely. We have valve cannulas. We have very small probes that come in really tiny sizes, 27 gauge. And the incisions just close spontaneously without need of sutures. So we have really exquisite control during the surgery. So it's really easy to remove all of the blood, all of the abnormal tissue in a very efficient and safe manner. So our surgeries have become quicker and safer for the patients. So, before, oftentimes patients bled a lot during surgeries and we had to close the eye and then do a second surgery at another time, and that doesn't happen anymore. And also with the injections, with the anti-VEGF injections, injecting some patients that have very, severe disease right before the surgery helps us have less bleeding during surgery. So if we think about the microincisional surgery advances that we have, 27, 25 gauge, and we couple that with new digital viewing systems, for decades, all that we used for surgery was a surgical microscope. And now we can do surgery with digital viewing. What that means is that it's very similar to kids playing video games, but with 3D viewing. So we actually have a very big TV and we have 3D glasses and we can see the image inside the eye very, very big, and we can digitally alter it so that we can see some structures much better. So it allows us to do better surgery and to visualize things best.
So Maria, I think that you've hit on many of the key advances for vitreoretinal surgical approaches from the retinal specialist perspective. I think the biggest concern for us traditionally was uncontrolled bleeding from these abnormal vessels. I would agree that by injecting these eyes with anti-VEGF within a short window before surgery and using these uniquely sort of targeted small cannulas that are valved to allow us to control the intraocular pressure has almost revolutionized the approach to complex diabetes. So you have been a big proponent of something that I think is very fascinating. You have mentioned that in particularly your younger patients, that you feel that there may be some significant benefit to early vitrectomy surgery. Could you tell our audience a little bit about what's brought you to that point and why you think that's important?
Yes. What happens is, as I mentioned before, in younger patients, that the vitreous gel is still attached to the retina. What happens is that no matter how we treat them, whether it's with laser or if it's with anti-VEGFs, usually if patients get uncontrolled or they miss appointments, oftentimes the retinopathy can get worse. And we know that in younger patients, we have the abnormal vessels growing into the vitreous, so their incidence of developing traction retinal detachment is very high. And repairing eyes that already have a tractional retinal detachment and that have either a traction, much worse, a tractional retinal detachment with a rhegmatogenous component are very, very challenging. And many of these eyes simply cannot be repaired. And many of these patients end up blind. When we look at published data of eyes of younger diabetics with advanced disease, we see a very high incidence of one-eye patients, patients that have lost all the vision in one eye, either with surgery or without, because they come in late. And in younger patients, if we simply do surgery and remove the vitreous gel and apply laser to the areas without circulation, we basically cure these patients. I have been in practice, for close to 30 years. And my patient population, I follow them almost forever. I'm married to them. So I have to see my successes and my failures for a very long time. And I decided to look at all my cases. And what I saw, which really surprised me, was that in eyes where I had done surgery in their worst eye because they developed a traction detachment or a traction and rhegmatogenous detachment, and the other eye was treated traditionally, when we look at them 10 years later, the eye that received surgery did so much better because younger diabetics get really stabilized once we remove the vitreous gel and we treat the areas of ischemia. They don't really develop edema because they don't have anything pulling on their fovea. So it's a surgery that really stabilizes them almost lifelong. And these are patients that may be 30 years, 40 years. They have many, many years to live. So I think we have to really do a paradigm shift. We don't have really any, besides the DRBS, which was done 40 years ago, when really we did not have laser, we had completely different machines. We don't really have any large-scale study investigating this. We have small studies, but what we see is that whenever we really intervene patients earlier, our visual results and our surgical results are better. So in my mind, when I see a young diabetic that has advanced disease, that has severe proliferative disease, or has had, a small vitreous hemorrhage, or is beginning to develop traction retinal detachments, I offer those patients surgery because I think it is the best thing. With the pandemic, I had two cases that were actually had, a little bit of proliferative disease in some areas, and they couldn't come in for about 3 months, and they all came in with severe tractional retinal detachments. So these eyes can progress very, very quickly into severe detachments.
So, Maria, I think you're correct about a paradigm shift. I think when you and I entered the field, the surgical instrumentation and the techniques were really not as advanced by far compared to what we have available to us now. And what that has allowed us to do, and you've really commented on, is we are moving surgical intervention for our patients earlier and earlier. And the take-home message, I think, is that when a patient needs vitrectomy surgery, that the better their vision is when you enter that eye and repair it, the better the visual outcome will be after. So I agree with you. I think that we are moving toward a better paradigm of how we should operate on these patients as well as when we should operate. And I also think that your comments about combining the pharmacologic treatment, the intravitreal injection therapy with surgery has played a big role. I've also found that there's some benefit in these patients of the use of an intravitreal steroid at times. So I think we're much more aggressive, and our toolbox to treat these patients now is much, much broader. What do you think will really help us over the next 5 years for these kind of complex patients?
Well, I think that we need to really think about, as you mentioned, all of the tools that we have that we never had before. So I oftentimes combine anti-VEGF and steroids. I think in patients with very advanced disease and very advanced edema, steroids work really well. So I tend to combine the two. I also combine that with PRP, with laser for proliferative disease in the periphery. And then I'm always very keen to offer surgery. Some cases of edema have some traction areas, have thickened hyaloid. They do very well with surgery. But the problem in the past is that we were using surgery as a last resort. So we were doing surgery on eyes that had spent 5 years with edema or 5 years with disease, and everything else had failed. So it was like a last resort. So of course, if somebody has had very advanced edema for 5 years, the vision is not going to improve even if we get rid of the edema. So I think being more aggressive, treating them earlier and offering early surgery, particularly with 27 gauge. I think 27 gauge vitrectomy with the new advances, which is the 20,000 cuts per minute dual opening of probes, allows us very fast surgery and very precise control of the eye and of membranes. So we can really, in the past, we had to use chandeliers, we had to use a lot of instruments to repair these things. Eyes kept bleeding during the case. Now with just, the vitrectomy probe, I can do most of my cases in a very swift, efficient way that minimizes bleeding and minimizes post-op complications.
So I think that's really where you've brought the attention of the retina specialist, is to earlier surgery, combined surgery with drug delivery systems, and the shift towards smaller instrumentations to allow access to some of these complex spaces. I can remember that the average surgical time when I started in retina was approximately 4 hours for a complex diabetic detachment. And now I think you easily see surgical times under an hour. And I think that the patients do much better with that shortened time in the operating theater. And because we are operating earlier, I think we're preserving function even more for these patients over the entirety of their lifetime. So I think that you and I would agree that if we could eliminate diabetes by controlling excellent blood sugars and hemoglobin A1C and losing weight and exercising and not smoking and sort of living the good life, that would be great. But I think that the world we live in still requires some amazing approaches to complex disease. And I think for you and I, this is one of the most complicated surgical diseases that we manage. So I'd like to thank you for joining me, Dr. Maria Berrocal from the Berrocal Institute in Puerto Rico. And for our patients and families listening, I'd encourage you to go to YouTube for the podcasts of this series that's also available through Apple. And our website for the ASRS, asrs.org/patients, has additional information on the diseases that we're discussing. You also can reach us on Facebook and Twitter. Thank you very much.
Thank you.